We're going to segue for the end of our lab meeting for a journal club, and Laura is here. Laura, again, is a longtime member of the lab for quite some time now, and Laura is now about to graduate from medical school and also to become an OBGYN intern, just like Carrie is now. And so we're really excited for her. And she also has a poster that's been accepted, and she'll be presenting next month at SASCOG, and a manuscript that will come forth from that too. So she's going to lead us today in our journal club discussion. And this paper was selected because of what I talked about earlier with Nora Volkow coming to VCU. And I'm not trying to like hype myself up, but I'm pretty sure she's probably going to mention this paper in her talk because she tends to do that when she gives talks. So I think it's good. Keep it, you can, if you go to her talk and be like, I read that paper, kind of hype yourself up. Okay, Laura, I'll let you take it away.
Yeah, sure. Let's see if I can get my screen share to work. Oh, Bhushan's so good. He already made me a co-host and everything. Amazing. Okay, is that full screen for everybody?
Yes.
Okay, great. Yes, so my goal now is to get you all super excited and prepared for Dr. Volkow's talk. So this paper is not by Dr. Volkow, but she wrote a commentary in JAMA that we'll talk a little bit about later. So hopefully she'll bring that up in her talk. But this is a longitudinal analysis of substance use disorder symptom severity at age 18 years old and substance use disorder later in adulthood. So let's see if I can get this to move forward. Perfect. Preaching to the choir here, 1 in 3 adults will develop a substance use sometime in their life, but the prevalence is a lot higher in that young adulthood period. But the USPSTF, who is, for those of you who aren't providers, is an overseeing body that tells providers what is and isn't worth screening for. So what kind of preventative services should we be offering to our patients? And at this point in time, they don't recommend screening for substance use disorder in adolescents, not because they think it's bad, but simply because there just isn't enough evidence to recommend it yet. But the American Academy of Pediatrics does. So if you've spent any time with Dr. Martin, you've heard her say SBIRT, and screening, brief intervention, and referral to treatment is what the American Academy of Pediatrics recommends for adolescents. So this study set out to examine the association between substance use disorder symptoms during that adolescent period and the presence of several outcomes: prescription drug use, prescription drug misuse, we'll talk about that later, and just symptomatology in general, whether that be a use disorder or an individual system at that midlife and later life periods. So how did they do this? Well, they started with a bigger umbrella study called Monitoring the Future. And this is a study that was funded by NIDA, the National Institute of Drug and what is it?
It's drug abuse. They're working on changing their name.
Okay, yeah, I went to go say it and I was like, that sounds bad. Let me figure that out.
Yeah, they're working on it.
So this was an umbrella study that monitored a lot of things, but it started in 12th grade, so seniors in high school, from 1976 to 1986. And it followed those people all the way, so 32 years until those people were 50. So I don't want to age anybody in the talk, but those people turned 50 in 2018, and that's where we got this data. So they surveyed from the time they were 19 to the time they were 30, 19 or 20 to 29 or 30. They surveyed them every 6 months, and we'll talk about what those surveys look like in a moment. And then they spaced that out after 30 to every 5 years. So every 5 years from 35 until 50. So that's a total of 10 surveys for each participant. 63% retention, which I think is huge when you're following someone for 32 years. I think that's a lot of continuity, but we'll talk about that in a minute. So what did these surveys look like? They use DSM-4 and DSM-5 criteria to add up the number of substance use symptoms. So symptoms like risking bodily harm, seeking substances. You guys have seen this criteria if you've spent any time in the clinic. And they put people into buckets of no symptoms, 2 to 3 symptoms, 4 to 5, and then that high risk group. So they're looking longitudinally at patients, but they're also quantifying severity. So these are binary variables, but we're getting severity information here. And they, interestingly, I'll be interested to hear what you guys think about that, put people in 4 buckets: alcohol use disorder, cannabis use disorder, a catch-all bucket of anybody else, and then they looked at a composite variable, overall substance use disorder. So that was a composite variable of the prior 3. That's not separate from. Prescription drug use in the survey were just questions like, are you taking these prescriptions that your doctor prescribed to you? These are things like sedatives or opioids for pain medication. And then they asked, are you taking other prescription drugs that are not prescribed to you? So those are binary survey variables. That's how they defined drug use and drug misuse. So I wanted to stop here because by the time I get to the end of these talks, I always forget the methods. Do you guys have any thoughts on that study design and methodology? I thought there were a couple big things here that they did not measure that were really important, but I'm interested if you guys had any of the same thoughts about this study design.
Probably a cohort study.
Okay, and what do you think is strange about that?
I'm just thinking about the study design. Sorry, Laura.
Oh, sorry. I thought you were like, why is this a cohort study? Yes, I remember your talk on this. I pulled it back up when I was reading this study. Yeah, it is a cohort study. But in the OB Motivate lab particularly, they didn't really measure opioids by themselves, which is something that now we think about. But it's important to remember that in this study, these people came of age as the opioid epidemic came of age. So I thought that was really interesting because I am kind of on the other end of the spectrum, and this has always been an epidemic my entire life. So that was a thought in the discussion of the methodology that I wanted to bring up here. Okay, so they ended up having over 5,000 participants. And when we keep that retention number in mind, I think that's impressive. They're predominantly white, female, and they measure their high school grades, which I just thought was interesting. So 73% of them had a B- or higher. But 1 in 5 of the 18-year-olds in this study had a substance use disorder, met criteria for a substance use disorder. That was most commonly alcohol use disorder, which I'll be interested to hear what you guys think about that later. And then the 2 extremes I put here, they were interested, I put it first, 11.5% of their participants had the highest severity, or 6 or more of those individual symptoms. But 20%, that 1 in 5, still had 2 to 3 symptoms. So while a lot of this study is going to compare the extremes, no symptoms to very severe symptoms, I don't want to lose these people in the middle who had quite a high symptom burden for being 18 years old. So what about their main outcomes? So prescription drug use. Are you taking drugs prescribed to you by your provider? Now, these aren't just any drugs, again, opioids, sedatives, etc. So that severity group, that highest severity group, 6+ SUD symptoms, were 1.5 times more likely to be taking those medications at all. They are 2 times more likely to be misusing those classes of medications. And they are 2 times more likely to still have 2 or more substance use disorder symptoms into adulthood. So this is your behavior while you're 18 years old, predicting at 50 years old what your substance use symptom burden will be. So this is teeny tiny and not the point for you to read it, but again, we're comparing no symptoms to the highest symptom severity. But if you take a look at this study again after this talk, the odds ratios for even 1 or 2 symptoms of substance use disorder are still in the 2, 2.5, 2.6, and sometimes 3 range. So this is really, they don't make this, I'm saying this, this is still kind of dose dependent. You're still seeing an effect at each of the levels. So this is the Nora Volkow paper that Dr. Martin was talking about earlier, and she talks a lot about this study's main limitation being survivorship bias. And what does that mean? That over time, the people who are more likely to drop out of the study are more likely to have severe substance use disorder. So we're thinking patients who overdose, obviously cannot fill out their surveys that are sent in the mail. Patients who are in residential treatment centers and might not be getting their surveys. So both the authors of this study and Dr. Volkow mentioned quite a bit that probably the sickest patients aren't being captured at the end. So this is an underestimate of severity. And then Dr. Volkow made a good point that they didn't measure tobacco at all, which seems like a big miss. It seems like a big miss. They measured alcohol, but not tobacco. And there was no stimulants, no measurement of stimulants, even in that all other catch-all bucket. When you go back and read that all other catch-all bucket is more like opioids, what we would think of as opioids today. So the take-home point that this paper and Dr. Volkow came to is that the substance use disorder symptoms in adolescence is associated with prescription drug use, drug misuse, and substance use disorder symptoms at 50 years old, 32 years later. And so they come to the conclusion that there is a role for screening adolescents as a means of preventing this from worsening or developing a substance use disorder at all. So this preventative medicine approach, rather than treating it once it's already come, which, as we know, the United States is not known for sure. I wanted to get your thoughts on, Dr. Volkow mentions the idea of substance use disorder in adolescence as a chicken or the egg issue. So did the adolescent have some sort of vulnerability that they were self-medicating and then they started using substances and continued? Or did they have some vulnerability to substances that then they continued? So this chicken or the egg idea. Also a cultural perception. And I put Animal House and marijuana as a gateway drug up here because I feel like, you know, my grandparents and parents were like, oh my gosh, marijuana is a gateway drug, and had a very different cultural perception than maybe my older siblings who were born mid-80s, kind of when this study was around, who grew up on Animal House, and there was kind of a glorification of this adolescent use of substances. So interested to see where you guys land on that. And what does successful prevention even look like? You know, we've all heard of DARE. We saw how that went. We're not super sure that was really effective. So what do we need it to be reimbursable for insurance? What does it take for us to prevent this, even 2 or 3 symptoms, to lessen this severity? So I would love to hear you guys' thoughts on this. Is this what you thought was going to happen or not?
Thank you, Laura. That was a great synopsis of this paper. I really liked Dr. Volkow's commentary too. I agree with you. I think she pointed out important things. I was curious because the cannabis thing was also, when you were mentioning earlier, when you took a break about the opioids not being in there, but cannabis was, and I think a lot of it has to do with the timing of the cohort, right? And thinking about how the role that marijuana was playing in the 70s, right, versus the role that marijuana is playing now. And I know we talked about marijuana at our last lab meeting a lot. So it's not really and I'm just pointing it out, right? It's just interesting because now we are in this day and age of the opioids, and then stimulants are coming out, and cannabis is, you know, a whole nother thing. But back, you know, when this study first started, well, at least the cohort that they selected for this analysis selected it from, it was a different thing, right? The opioids weren't on the rise, but the cannabis was a big problem. And alcohol use disorder has always been the most common substance use disorder. So it is just interesting how we have this great data, right? That's over decades. And you're like, this is great. We have, decades of follow for this cohort, but there's always going to be a limitation because of shifts and a lot of things. One, just culture and trends in substance use. So I feel like there's always a catch to a great study.
Yeah, absolutely.
Thank you, Laura. That was a great summary of this article. One conversation I heard that we had at the ASAM conference, there was a poster from Yale Addiction Medicine Program, and they're doing like in-school addiction treatment for like high school students. And so they're screening students and then trying to engage them in care in high schools. Not like giving meds there, but at least like screening and offering like behavioral therapy and stuff like that, which I thought was really interesting. And I had a good conversation with the guy about like different experiences that people are starting to have treating people younger and younger. So I feel like it's very much like untapped and kind of probably under-screened and under-treated.
Yeah, I think I was blown away at just the overall, like, people who were 18 years old and met criteria for a substance use disorder. Like that's wild to me. Yeah, I think I was overwhelmed at the sheer volume of it, for sure.
I can't remember in the article, but when you're talking about survivorship bias, that's definitely, a real consideration. Did they look to see if, were the people who actually were screening higher dropping out at a higher rate than those who were lower as severity?
Oh, sorry. They didn't mention it in the paper. They did note that all of their analyses were attrition weighted to make sure that they weren't skewing the analyses one way or another. I'm not going to lie to you. I don't really know what attrition weighted is, but that's the way they described it. So I feel like statistically they worked as hard as they could to mitigate that bias, but they just mailed these to home addresses, like in the regular old snail mail. So if you weren't there to get your mail, fill it out and mail it back. Your data was not entered. So I think that was also a large limitation, but again, it was the 80s. So a little bit of a different methodology than we would have used today.
Awesome, thank you. Also, we still use a lot of mail surveys, so we haven't progressed that far. We actually still do a lot of addiction evaluation by mail surveys. But yeah, it's a problem because obviously people who are moving a lot or very transitional, or like you said, in residential places, like are not going to be the ones getting those surveys, so you miss their data.
Right.
I just had a comment about the gateway drug being marijuana. Empirically, like I've seen, I guess, my short-lived clinical research experience, there are participants who completely don't even acknowledge ever using marijuana, but they're using heroin or they're using prescription opioids. So I'm not sure the validity of marijuana as being a gateway drug, because there are people who say they never smoked marijuana before, but they are using, So I don't know, just anyone can comment on that.
I think that was just part of the messaging back then to try to keep people from starting marijuana and using marijuana. Because, they used to have bong shops on every corner.
Right.
And then they closed them for a certain amount of time and then they opened them. I mean, so I think it was just a matter of how do we stop this? And then it was, oh, if you start here, you're going, just going to go to the next harder thing. That's just what you're doing. And I think that was just the messaging at the time. I was kind of curious, Laura, first of all, great presentation. Very interesting information. I'm sorry, I haven't read the article, so I'm just learning from you here. I am very curious about the chicken or the egg. And what I wonder is, like, some of those outcomes, did they have any more information about that? Like, the people that when they were younger that had the substance use disorder that are now obviously either taking prescribed medications for things, I'm assuming like anxiety and so forth, that perhaps as a younger age, they were using marijuana or alcohol to kind of relax because they were anxious or they had things going on in their family. Was there anything along those lines? I mean, it kind of does seem if things weren't taken care of. So was there anything with therapy in there or like?
Yeah, I'm trying to find exactly where she says it. It may reflect underlying vulnerabilities that manifest early and persist through life, or self-medication, which in adulthood transitions to seeking medical help for those conditions. So I get what you're saying about where is this coming from and how would they measure it. And at the end of the day, they're not really sure whether it's the medications or substances themselves that are changing the neurobiology to make you more susceptible, or vice versa. They don't really have much data on it, unfortunately. Yeah, I don't have a good answer. I'm sorry.
Yeah. No, it's interesting though.
I was trying to find there's a quote in this paper. It was the overwhelming majority of people who misuse prescription drugs were in that higher severity substance use disorder symptom group. So they're very highly represented in the group that has prescriptions in those categories. Like, I mean, we're talking about things like trazodone or any sort of pain relieving medications. People who get those prescriptions at all are people who had substance use disorder symptomatology early in life. And we know that having those prescriptions is a risk factor for developing a later use disorder. So it's really circuitous. Yeah.
Sense. I mean, yeah, it does make sense. Yeah. But we're trying to figure out what to target to prevent, so.
Exactly. Yeah. And I thought it was interesting what Carrie said, that they were using behavioral interventions at Yale, because that seems like to me, I don't know what you guys' thoughts are, but to me, that seems like a very doable thing in schools because they have mental health care providers. If you were going to bring medication therapy into schools, that's a whole different ball game. But I liked what Carrie said Yale was doing with just targeting behavioral interventions, because what if it is that underlying psychiatric condition that the person is self-medicating, and could we start there? Yeah. I'm glad she brought that up. Thank you, Carrie.
I don't work in the prevention space, so I always think it's interesting. You guys know I work in the treatment space, but at the Women's Health Research Day, one of the speakers works in the gender-based violence space, and a lot of her work revolves around teen dating violence. And so she was presenting on some of the cool stuff that they're doing from a prevention standpoint. And there's so many correlations to substance use and what she was talking about. And she, again, I'm going to recapitulate it in a bad way, but it's just the multimodal approach that they were using, integrating into the schools, integrating into communities, doing family-based intervention, so parents and their daughters together, and using everything from like art therapy all the way to, cognitive behavioral therapy, and then just group activities. And it wasn't direct. And a lot of the examples that she gave, again, I always think prevention stuff is interesting because I don't do it and it just sounds like so much fun, was not specifically like, date the right people and these are the signs of abuse or, things like that. It was other things like self-confidence and working on what is a healthy relationship, what is being healthy for yourself mean, and like really going at it from the umbrella perspectives and kind of in an indirect way, trying to get that downstream effect of decreased risk of violence, this teen dating violence was the outcome she was interested in. So it was just funny because we went there last week and I was reading this paper thinking about all the prevention work that people work on for substance use. And it sounds like, we need to be doing something similar to that space, using a multimodal approach, using strategies that are tailored specifically for the population that you're working on. So she was talking a lot about community-based methods of the development of all the materials. And so I really like that area, and I think you're right, Laura, with the example with integrating to the schools, we really do need it. I was super blown away by the high prevalence, just again, not an adolescent medicine provider. I didn't realize how high of a prevalence all these use disorders were at age 18.
Yeah. And I think what the talk that you were talking about, the thing that jumped out at me when she said that is, and this is unnecessarily gendered, I understand that before I say it, but she said, we are bumping up against a cultural message that if boys are mean to you, that means they like you. And in this paper, Dr. Volkow mentioned, we're bumping up around the cultural message of they're just going to grow out of it. They're just experimenting and they're going to grow out of it and it's going to be fine. And that's just not really true based on this data, which I was really surprised about. I was certainly steeped in that cultural message of, sow your wild oats in college and then get it.
Yes, I was just going to say, how do we change the culture of college?
Right.
I mean, high school is a big party ground, but college is like triple the party ground for a lot. And I'm talking like high level colleges. It could be really rough. I mean, I know some smart kids these days that have had to leave school, not because they weren't academically very smart. They couldn't keep up with the peer party culture that they weren't able to not be involved in, and some men, especially, and the boys, they have trouble with that. You want to be in with that group, so I think that we definitely have some issues still. I mean, definitely around partying at the schools, and the expectation of what that means, I guess, for young adults.
And Dr. Volkow mentioned, I mean, Dr. Martin was saying earlier, like the trends and how substances ebb and flow across generations. And I was just reading about, how much Adderall is on college campuses. And Dr. Volkow was talking about how stimulants weren't even in this, it wasn't even in the sphere yet. Right. Opioids was a fringe. Stimulants were not even in the frame. And now Adderall is such a large player in that age group for sure.
Yeah, that's very true. In our age group, I don't remember the stimulants or the Adderall being a thing in college, but I know my own students where I taught for years coming to me like, so-and-so stole my, what, so the stimulants is a big deal now, unfortunately. And again, is that the stress and the competition and the expectation? I don't know. There's a lot of competition right now. Prevention, that's huge. Yeah, lots to think about, right?
It's just not something we do well as a country. It's just not our jam, but we're working on it.
That's Europe, yeah.
I'm just curious when someone does the same study in, X number, I can't do the math, X number of years later from our 18-year-olds today, right? Later on, what the results are going to show. Monitoring the Future is a huge cohort study that is ongoing, and is the main source of, just for people to know, it's the main source of information that we have about adolescents and young adults and substance use and behavioral health. It's the equivalent to NSDA, or National Survey of Drug Use and Health, for adults, which is again the national annual survey that's sponsored by SAMHSA. So they're sponsored by different people, but they're essentially the very same thing. It's like our way to get numbers. So I'm just curious when they do the study in X number of years from our 18-year-olds today, are the findings that they had for cannabis use disorder, or is that what we're going to see for opioid use disorder? Or is it going to be the same? I don't know. Because in table 3 for cannabis use disorder, people who had just 2 to 3 symptoms in the DSM-5 or DSM-4, their odds ratio of developing a substance use disorder, later on in adulthood was 2.85, so almost 3 times. So again, this gateway drug idea, I think it's just, the answer is yes, based on this, right? There is an association between cannabis use disorder, maybe not cannabis use, right? Those are 2 different things. Going back to your initial question, Laura, and later on. But I'm just curious, are we going to have those same findings for opioids later, or are these odds ratios going to be worse? Or are they going to be the same? Because I feel like potentially, again, because of the trends, we might see something similar for opioids later in the future when they have the 18-year-olds today turn 50.
Yeah, and I thought, I was trying to think about patients with the chicken or the egg story, and I thought about, like a patient who has underlying fibromyalgia and is self-medicating their pain, and then goes on to get a legit prescription, and then leads to prescription misuse. Or do they start using opioids when they were younger and get hyperalgesia, and then kind of fall chicken or the egg? And I don't know when or if we'll have the answer to that.
Well, another thing Dr. Volkow will definitely talk about in her talk are the studies that NIDA's funding that try to get at the chicken and the egg. So they have these multi-million-dollar studies called the ABCD study, and then I forgot the acronym for the other one that starts with prenatal and babies. And so they have these very large cohort studies that they're doing now, funded by NIDA, that involve a lot of fancy things, but there's one HBCD, I don't remember. There's some type of acronym for the ones that start with babies, and then there's another one that starts with children, and then follows them, kind of like monitoring the future. But they add on a lot of fMRI brain stuff, and then a lot of very in-depth surveys with the parents and the children. So NIDA is trying to figure out the chicken and the egg thing. So another reason why I think she wrote a commentary on this paper.
Anything else we missed?
One thing I will note that I noted when I was reading was the differences between, so when they looked at the odds ratios, like in table 2 versus table 3, like table 2 doesn't adjust for any of the covariates that they included, which is like age, sex, race, I can't remember the other ones. So they looked at the correlation or the association between, again, the age 18 substance use disorder symptoms and those at age 50 or whatever, adulthood. And it was interesting to me how the odds ratios do become attenuated. So like the odds ratio for like the simple one, if you had 2 to 3 substance use disorder symptoms at age 18, your odds ratio without taking into consideration the other things that they measured was 3 for developing substance use disorder 2 symptoms in adulthood. But then it goes down, the odds ratio goes down to 1.89 in table 3 when they took into consideration their covariates, which include a few different things that they have that they list there. So I think it's just, they don't comment at all about that. And it's kind of an obvious thing, but I just feel like it probably deserved a sentence in the discussion about how, it's not just the substance that puts someone at risk of substance use. And I know there's one thing about the chicken and the egg, right? Was there something that set up this adolescent for substance use disorder, or is it the substance use itself that led? That's one thing. But I think in addition to what we've been talking about with the chicken and the egg, it's not just the substance that leads to the risk later on, right? It's the substance use in the context of someone's environment, right? And life experiences. And that is very clear by the fact that, their odds ratios change. You can, at least quantitatively, you can see it here when they took into consideration at least the very few covariates that they had. They're not even taking into consideration social support, all these other things that we do like to get in our observational studies. So again, just remembering that prevention, screening, and substance use is super important, but it's also, if you're helping people in other ways too, for comorbid conditions, psychosocial supports, et cetera, all those things also are playing a role from a prevention standpoint at the same time.
Social determinants of health.
Yeah. Well, awesome. Anyone else have any other comments or questions?
Thank you all for your time and attention on this very rainy, gloomy Monday. It's been sad all day outside.
Well, awesome. Great job, Laura. That was a great discussion about a really interesting paper. Great. Well, we will end now, and it was good to see everyone. And thank you so much for coming to our lab meeting, and we will see you next month. Bye, everyone.